Hi, everybody. I'm Alexandru Michi. I'm the chair of the Telecardiology Working Group of the International Society of Telemedicine and eHealth. We are so happy to have so much participants today. We had at least 800 subscribers. We have a very interesting topic, amyloidosis, everything you need to know, with exceptional speakers. Maybe without further delaying our webinar, I would like to introduce and thank you for her time and help into preparing this webinar. Our colleague Michelle Kittleson. Michelle, hi. Can you please briefly introduce our webinar?
Yes, I'd be happy to. So delighted to have everyone on board because there's no greater topic of excitement and interest in cardiac amyloidosis. You're going to hear about cardiac amyloidosis, what you need to know. We're going to cover the clinical flags, red and clues. We're going to cover the imaging, the diagnostic algorithm, the current treatments, and future promise. So stay tuned. By the end of the hour, you will know everything about this important condition.
Thank you so much, Michelle. And I have also the utmost pleasure to introduce the first speaker, which is Michelle. So Michelle, you will talk about the red flags and clinical clues. Thank you so much once again to you and to all the speakers for your time.
Awesome. Well, here we go. So cardiac amyloidosis, red flags, and clinical clues. Because everything's more interesting when we talk about a patient. Let's begin with a case. So a 72-year-old woman presents with a 2-week history of shortness of breath. She has hypertension, paroxysmal atrial fibrillation, and osteoarthritis. Her medications include rivaroxaban, chlorthalidone, amlodipine, and ibuprofen as needed. On examination, BMI 31, heart rate 68, blood pressure 142/88, JVP 10, heart regular with an S4, 2+ edema. Echo shows mild increased LV wall thickness, EF 60, mild aortic stenosis, and mild pulmonary hypertension. So what is the most likely diagnosis? Now, of course, I know you're probably thinking that the most likely diagnosis is heart failure with preserved ejection fraction. And in this case, I think you're probably right. Now, when it comes to cardiac amyloidosis, that's always possible. More on that in a sec. Hypertrophic cardiomyopathy, she's a little old for it, and our hypertension explains the increased wall thickness. Aortic stenosis, not really significant by exam or echo, and pulmonary arterial hypertension, again, echo's not that bad, doesn't fit the demographic. So when it comes to heart failure with preserved ejection fraction, one helpful diagnostic score is the H2F/PEF score, which takes into account body mass index, hypertension, atrial fibrillation, pulmonary hypertension, age, and filling pressures. Our patient here ends up having a score of 8, which gives her an over 95% probability of HFpEF. But say we tweaked the details of her case. Say we said, instead of having a 2-week history, it's more prolonged. Instead of just shortness of breath, she has some vague fatigue. She doesn't have hypertension, but she does have carpal tunnel, spinal stenosis, peripheral neuropathy. And on exam, she's not overweight. She's not hypertensive. Her GVP is significantly higher. Her echo looks exactly the same. In this situation, I'm going to convince you that the most likely diagnosis is cardiac amyloidosis. Now, the problem is, if you did her H2F/PEF score, it would actually be 5, which gives her an 85% probability of HFpEF, but the question is it HFpEF? So the problem is that HFpEF, that garden variety heart failure with preserved ejection fraction, is a diagnosis of exclusion, which is the hardest diagnosis to make. You must go through your differential diagnosis and convince yourself that you have excluded other treatable, reversible causes, like a restrictive cardiomyopathy, hypertrophic cardiomyopathy, valve disease, right heart failure, obstructive lesions, pericardial disease, or high output heart failure. Now, a lot of these can be ruled out with an echocardiogram and a history, but it's so important to assess for these causes because there may be disease-directed therapy. What are some clues that you're not dealing with garden variety HFpEF? Patients are younger. They don't have the typical comorbidities, the AFib, hypertension, diabetes, obesity. They don't have progressive symptoms. HFpEF tends to wax and wane with exacerbations, whereas something like cardiac amyloidosis has more of an inexorable downward trajectory. And there's often relatively low QRS voltage because it's not heart muscle that's causing the increased LV wall thickness. So when you think about cardiac amyloidosis, quick overview, as we know, there are these proteins that infiltrate the myocardium, causing a restrictive cardiomyopathy. The protein generally comes from two main sources, immunoglobulin light chains, AL, or the TTR protein, TTR. That TTR protein can then come from one of two sources, a mutation in the gene, which would be the variant or hereditary form, and then wild type, which used to be termed senile cardiac amyloidosis, but we don't like to hurt people's feelings. We don't call it senile anymore. We call it wild type. And the protein just doesn't infiltrate the myocardium. It goes other places too. So don't forget about the neuropathy, the nephropathy, unique to AL, GI involvement, gastrointestinal involvement, and orthopedic issues. So if we circle back to the patient, her more protracted course, her nonspecific symptoms, her orthopedic and neurological complaints, her lower BMI, her lower blood pressure, the fact that her mild increased in LV wall thickness couldn't be explained by her blood pressure, all tie into saying something different is going on here. So when you think about amyloidosis, remember that heart failure symptoms are the tip of the iceberg, and you have to remember what lies beneath. There's other cardiac issues that should be red flags, when there's atrial fibrillation, when there's conduction system disease, aortic stenosis, and garden variety HFpEF. In case series of patients with severe AS or HFpEF, about 15% actually have cardiac amyloidosis, a missed opportunity for disease-directed therapy, and the increased LV wall thickness with discordant QRS voltage, neurologic, sensory neuropathy, but also autonomic dysfunction. Remember that a lot of these wild-type TTR patients are older, maybe hypertensive a little bit. You try to start them on a vasodilator, their blood pressure plummets, often a sign of autonomic dysfunction. And the orthopedic issues, carpal tunnel and spinal stenosis. Now, I can't not talk about this amazing study, hot off the press, using machine learning to diagnose cardiac amyloidosis. So Dr. Sanjeev Shah and his group at Northwestern took diagnoses from the electronic health record and extracted these ICD-9 diagnostic codes, and then used machine learning with a random forest model to identify those phenotypes and phenotype combinations that would suggest cardiac amyloidosis. They then validated it in 4 cohorts and phenomenally had an area under the receiver operating curve of 0.8. Some of the highest yield features turned out to be abnormal enzymes like BNP and troponin, atrial flutter, cardiac conduction disorders, shock or effusions, neuropathy, carpal tunnels. So to put it all together, remember that when you have a patient with congestive symptoms and an EF of 50% or more, first figure out, is it the heart's fault? There might be a mimicker, renal failure, liver failure, severe obesity with edema. But if there isn't, and it is the heart's fault, figure out if there is an underlying disease-directed cause. Go through your differential. And finally, you can allow yourself at that point to relegate the patient to a diagnosis of exclusion of HFpEF. Well, that's all I have to say. Thank you so much for your attention. And we are going to now segue to our next fantastic presentation by Dr. Benjamin Essayagh. Now, he's going to work on sharing his slides while I introduce him. So Dr. Essayagh is part of the Division of Cardiovascular Disease at the Mayo Clinic in Minnesota, as well as Caen Hospital in France. And he's going to talk to us about the role of imaging studies in the diagnosis of cardiac amyloidosis. Off you go.
You need to unmute.
You have to unmute, Benjamin.
Here we go. Thank you so much. I was just saying that it's a pleasure and both an honor to be speaking today about the imaging presentation. And indeed, amyloidosis is a fascinating disorder of protein misfolding where we have at least 3 protein causing cardiac amyloidosis. as we said, and usually we have this presentation of thick LV, thick RV as well. We have LA and RA that are dilated, and here is the case, because it's not always easy to diagnose, of a 63-year-old man that is presenting with dyspnea and fatigue, that has a story of hypertension, type 2 diabetes, that has clinical signs of heart failure, and the echo shows a systolic LV dysfunction. The LV is hypertrophic, and the RV is dysfunction as well. And this patient has an echo that correlates with infiltrative cardiomyopathy. So the question is, what is an infiltrative cardiomyopathy? And amyloidosis, of course, is not the only cause of those infiltration characterized by the deposit of abnormal substances in the heart that are causing myocardial dysfunction. And it could be HCM, it could be amyloidosis, it could be Fabry disease, it could be sarcoidosis. So the diagnosis requires a high degree of suspicion, and imaging and lab are essential, and basically it represents a cardiac manifestation of a systemic disease. Before we go into deeply the imaging characteristics, briefly the burden of cardiac amyloidosis, and Michelle said it brilliantly. When you have HCM with diastolic dysfunction, we have at least 15% of patients that have cardiac amyloidosis. Speaking of HFPEF, we said it's around 15 to 20% of patients. When we have patients with severe aortic stenosis that are undergoing TAVI, 20% of them have cardiac amyloidosis. So it's more frequent than we previously thought. And another crucial point is the delay between the symptoms and the diagnosis, which is in at least 70% of patients done 6 months after the onset of symptoms, because the symptoms are vague. So our challenge is to make an early diagnosis, because this is a major factor of poor prognosis when that is delayed. So we've said it, the EKG is going to help us here. We have a first degree AV block, we'll have a left anterior fascicular block, we have atrial premature beats and a borderline low voltage. But the echo is going to be the first imaging modality, and the echo as well is not that easy, because here you see two patients with cardiac amyloidosis. The patient on the left has a normal EF and no thick LV. The patient on the right has a more advanced disease with a low EF and very thick LV. So when we are at the early stage of the disease, we don't necessarily have the LV hypertrophy, and we don't have any restriction. When we are at an advanced stage of the disease, we have LV hypertrophy, and we have a high degree of restriction. When otherwise, we have a classic presentation of amyloidosis here. We see a severely increased LV wall thickness, where the LV shows granular sparkling, which may be seen in cardiac amyloidosis. We have a pericardial effusion that is very characteristic of the disease. We have both LA and RA dilatation that reflects elevated filling pressures, as well as atrial infiltration of amyloid protein. And we have often the RV wall thickness that is elevated as well. So the hypertrophy is gonna help. The other point that is going to help on the echo is the Doppler imaging, because you may have a cardiac amyloidosis with a normal or relatively normal mitral inflow parameters. But when looking at the pulmonary venous Doppler flow, here we see that we have an abnormal flow with a predominance of diastolic flow. We have abnormal tissue Doppler imaging that shows a reversed E and A prime ratio, suggesting of pseudo-normalization of transmitter flow. And E on E prime is elevated as well, consistent with elevated left ventricular filling pressure. Looking at the left atrial, we'll have a poor LA function. And here we see the loss of atrial function of the mitral inflow, with a normal deceleration time, but a small A wave in a patient with ATTR amyloidosis in sinus rhythm, patient who presented with stroke because of a thrombus formation related to LA dysfunction. And we see here on the bottom left side of the screen, pulmonary venous flow, again in a patient with ATTR amyloidosis, that demonstrate almost exclusive diastolic flow because of restricting filling pressures. And the atrium function, when we assess that by LA strain, has a loss of both the contractile and the reservoir function in compared to a patient here with a normal LA strain. Some patient with a high degree of LV thickness might have an obstruction, and this will have will show the obstructive phenotype. But looking at the valve as well in echo can help, because the infiltration occurs also in the aortic and in the mitral valves, and can be easily shown in pathology specimens. And finally, the echo in a patient with cardiac amyloidosis is going to be very helpful regarding the left ventricular strain. That shows that strain is altered, but there's an apical sparing pattern that is kind of characteristic in amyloidosis, because the infiltration starts at the base and the middle segments of the left ventricle. So here we see a severely reduced global longitudinal LV strain, -2 or 3, with an apical to basal strain ratio over 2.5. And we have this so-called cherry on the cake pattern on the bullseye. That is very characteristic of cardiac amyloidosis, and is different to other infiltrative cardiomyopathy. When we look at HEM here, and the strain pattern will have isolated impairment of the septal longitudinal strain in septal HEM, whereas in aortic stenosis we'll have a pachyreduction of the longitudinal strain in related to the left ventricular hypertrophy of aortic stenosis. So echocardiography is going to have to do the diagnosis, but we'll use cardiac MRI as well to have making the diagnosis. And the cardiac MRI will show a diffuse late gadolinium enhancement with a difficulty to null the myocardium. And this diffuse late gadolinium enhancement is shown in comparison to a normal cardiac MRI, where the myocardium is dark here in a normal patient. It can be seen in the LV. It can be seen as well in the LA, and both LA and LV show that diffuse late gadolinium enhancement that is clearly seen and is kind of 90% specific in cardiac amyloidosis. The third imaging technique that we are going to use is the scintigraphy. With here on technetium 2D scintigraphy will show a strong myocardial tracer uptake, and thereby confirming the diagnosis of ATTR amyloidosis here, and will be able to grade the severity and the severity of the uptake. In here in the top part of the screen, revealing equivocal, we will say grade 1 uptake in patient with AL amyloidosis, whereas here in the bottom, we'll have a strongly positive grade 3 uptake by the heart when compared to the surrounding grids in a patient with the ATTR wild-type amyloidosis. The scintigraphy can be done by single photoimmunization with technetium as well, and here we'll have 3D images at the top showing intense diffuse rest left and right ventricular myocardial uptake in a patient with ATTR amyloidosis. That is kind of different when we don't have a hypertrophy linked to amyloidosis, because here we'll have a blood pool activity and no myocardial uptake in a patient with a non-amyloid LV hypertrophy. The same images can be obtained with using a different marker. Here the floor beta appear. So the question is, now that we have the 3 imaging techniques, the echo, the MRI, and the scintigraphy, how do we integrate those 3 in the diagnosis of cardiac amyloidosis? And when we have an equivocal clinical presentation, we have a suggestive EKG, we'll have a suggestive transthoracic echo, we'll look at the bone scintigraphy, and when we have a strong cardiac fixation that will likely evoke ATTR cardiac amyloidosis, but be aware that no cardiac fixation cannot exclude the diagnosis of AL, as 7% of patients with AL do have a cardiac fixation. We'll go deeper in the diagnosis of cardiac amyloidosis and the algorithm. So I think I'm done with this, and I thank you all very much for your attention.
Thank you so much, Benjamin. So I have the pleasure to give the word to Frederick Ruberg, Associate Chief of Academic Affairs at the Boston University School of Medicine. So Rick will present the diagnosis algorithm, the role of the monoclonal light chain screen, and genetic testing and biopsies. That is a very long title. Hi, Rick.
Big topic. Can you hear me okay?
Yeah.
Excellent, great. Thank you so much, Alessandro and Michelle. It's really an honor to be here and to participate. So yes, big title, diagnostic algorithm, monoclonal light chain testing, genetic testing, and biopsies, all in 8 minutes. I'll do my best. So let's just review what you just heard about the non-biopsy diagnosis for ATTR amyloidosis. It requires a combination of looking at imaging. In this case, this is PYP, but you can also use DPD or HMDP. And you look at the ratio of uptake of the heart to the bone, in this case, rib. You also can look at the ratio of the heart to the contralateral chest, which is verified in PYP imaging. And if at 1 hour it's more than 1.5, or you have grade 2 to 3 uptake equal to or greater than rib, you can diagnose that scan as consistent with ATTR amyloidosis. Now, the other half is the plasma cell analysis. The patients cannot have any evidence of a plasma cell abnormality, and that's assessed by serum-free light chains using the light chain assay, immunofixation electrophoresis of the serum and the urine, not plasma electrophoresis, but plasma electrophoresis with an extra step of immunofixation, which is much more sensitive for identifying a monoclonal protein. The point here is that you want to identify AL amyloidosis because AL amyloidosis is rapidly progressive and could kill the patient. And so this is how we put it together in our algorithm. This algorithm was generated by Dr. Kittleson as chair of this guidelines document and Dr. Maurer as vice chair, and I had the privilege of participating. And the concept here basically is you suspect cardiac amyloidosis, and that's another important point. The patient has to be in the right clinical scenario to suspect cardiac amyloidosis, exactly as Dr. Kittleson presented in the first case: increased wall thickness, heart failure, carpal tunnel syndrome, spinal stenosis, other things like that. If you think there's something else that might be going on, get a cardiac MR, rule out hypertrophic cardiomyopathy or constrictive pericardial disease or something else to that effect. But if you think the patient has findings consistent with cardiac amyloidosis, get that light chain test, get the immunofixation electrophoresis. If it's abnormal in any way, or you're not comfortable interpreting it, get a hematology consultation. The hematologist will probably obtain some biopsy of some sort if they're concerned about a monoclonal gammopathy, multiple myeloma, or AL amyloidosis. And that biopsy could be from the fat, it could be the heart directly, or another organ that could be affected. If the hematologic evaluation is negative, then you can proceed with PYP imaging. And I would say you could probably get both at the same time because you don't want to slow down at all. This is potentially an urgent problem, especially if it's AL. But if the PYP scan shows evidence of amyloid and the light chain evaluation is negative, then you're down the pathway of saying this patient likely has ATTR cardiac amyloidosis, and it's just a matter of doing the genetic testing. When it doesn't fit together, proceed to biopsy. And that's the point I wanted to make here. Assessment of cardiac amyloidosis using non-biopsy methodology requires integration of these tests: the serum-free light chain ratio, the immunofixation electrophoresis, and the imaging and scintigraphy. And only if they all align perfectly, the light chain ratio is normal, the immunofixation is negative, and the PYP scan or DPD scan looks like ATTR, there's fixation or uptake, that patient has ATTR-CM without any further diagnosis. You don't need to do a biopsy in that case. But if anything is inconsistent, the light chain ratio is abnormal, there is an immunofixation band identified by serum or urine, then you either have to get tissue or certainly get a hematology consultation. And I call your attention to the scenario of older people. Older people tend to have chronic kidney disease. Chronic kidney disease increases the kappa to lambda ratio in the light chain analysis because kappa light chain is cleared renally. In this setting, you could have just physiologic elevation in kappa that's over the upper limit of normal, but not AL amyloidosis, and certainly not a monoclonal gammopathy. And that's where you need your hematology colleagues to help you. Now, turning to biopsies, cardiac amyloidosis is diagnosed by endomyocardial biopsy as the gold standard. And we still do this in situations of confusion, as I just illustrated. The biopsy shows Congo red staining with characteristic green birefringence by polarized light microscopy. This is what this is what cardiac amyloidosis looks like, but it doesn't tell you the type. To determine the type, you need to actually go ahead and do either immunohistochemistry or, more preferably, laser dissection tandem mass spectrometry, which is done as a send-out exam in certain centers around the world. I'll show you the power of LCMS in the next slide. if you have a pathology department that has facility and experience with IHC, immunohistochemistry, you can do IHC, but IHC is subject to the sophistication and also to the experience of the pathologist, and sometimes it can be wrong. But using IHC, this is a control patient, 2 patients with ATTR amyloidosis and 1 with AL. You can see that the light chain amyloid stain is the AL patients, but doesn't stain up the TTR patients, whereas the TTR stain stains TTR. Doesn't tell you whether it's genetic type or not. It just tells you whether it's AL or ATTR. We call this the type of amyloid or the precursor protein. But when you're not sure, you should go ahead to LCMS. And even at our center, where we have a lot of experience in pathology, we often will reach out to LCMS, which in the United States is done as a Senate exam to Mayo Clinic. In this particular paper, which was published by our colleagues at Mayo, fascinating paper that showed 2 types of amyloid in the same biopsy specimen identified by LCMS. This is a cardiac biopsy showing interstitial amyloid, samples 1 and 2, which shows TTR here on the proteomic analysis. And in the perivascular space, samples 3 and 4, light chain. This patient has coexistent TTR and light chain amyloidosis. It's rare, but it can happen. And this is where I think you need to have a high bar for either getting hematology consultation or proceeding with cardiac biopsy. What about fat aspirate? Well, we do fat aspirates at our center frequently. Fat aspirates are quite good for AL amyloidosis. These are data actually from our colleagues at the National Amyloidosis Center in London, but it's terrible for ATTR wild type amyloidosis. The most common type of amyloid is poorly identified by fat aspirate. So if you think your patient has amyloid and the fat is negative, it doesn't mean they don't have ATTR. They could certainly have ATTR. They would less likely have AL, however. And other variable biopsies, I'd say, vary by sensitivity and specificity. We don't typically perform surveillance biopsies unless an organ appears to be affected by amyloid. I will tell you that you can generally infer the presence of cardiac amyloidosis with supportive imaging findings of amyloid with extracardiac biopsy. So if the extracardiac biopsy of, say, the kidney shows AL and the heart looks like cardiac amyloidosis by cardiac MR or by nuclear imaging, by cardiac MR or by, if you had a PET, or by echo, I would say, then you can say the patient has cardiac amyloidosis. But you have to be aware of those overlap scenarios. Older patients with monoclonal gammopathy could have ATTR amyloidosis. Younger patients with multiple myeloma could have AL, or less likely hereditary. So you have to be quite careful. And again, proceed to biopsy when things are not entirely aligning. I wanted to call your attention to tenosynovial biopsies and ligamentous biopsies, because these are an emerging area of potentially the means to identify early disease patients. Dr. Kittleson already talked about the findings of carpal tunnel and spinal stenosis. Well, it turns out if you start sampling patients who meet certain criteria, older people typically in general, and I fit into this age group, so which is embarrassing, but for having said that, but these patients, they actually identified 10 new cases of amyloidosis, 2 ALs, the rest were ATTRs, but almost none of them had cardiac involvement. So the idea here basically is that you can use these sorts of biopsies for identifying systemic disease even before there is clinical manifestation. In the last minute or two, let's talk about genetics. This is a nice figure from Dr. Maurer's recent review that really illustrates the genetics, the most common genotypes associated with hereditary amyloidosis. As you heard, cardiac amyloidosis from ATTR can either be hereditary or wild type. The hereditary amyloidosis results from a polymorphism in one of the 4 exons of the TTR gene that's passed on in an autosomal dominant manner, which means there's a 50% chance that a child of a proband will also get the gene. They're abbreviated by the substituted amino acid from the original amino acid at the point of the variant. And these variants are really interesting because some of them have cardiac features, some of them, have neurological features, and some of them have a mixed phenotype. The most common variant that causes cardiac amyloidosis worldwide is the V142 variant, which is seen most commonly in the United States and in the United Kingdom of people of African origin. In fact, in the United States, 3.4% of self-identified Black people harbor this variant, which actually translates into 1.5 million people harboring the variant. The penetrance, though, is probably low, although it's age dependent. And this study published by our colleagues at Brigham and Women's Hospital shows that in a reanalysis of the ARIC study, there was no difference in carrier state in terms of survival, but over the age of 70, there was a drive towards increased heart failure risk in patients who are carriers of the allele. Now, they looked at clinical penetrance based upon echo. And so even though they inferred a relatively low clinical penetrance, there was something that clearly was driving heart failure over the age of 70. And perhaps with more sensitive techniques, they would have identified more cases. It's very clear that the allele, though, clearly drives the development of heart failure, or is associated with it, I should say. And this gene bank study from our colleagues at Penn and Mayo and Mount Sinai showed that there's a 60% to 80% increase in the risk of heart failure in carriers of the allele. Again, 1.5 million people carry V122I in the United States. How many of them, even assuming a conservative penetrance of 7 to 10%, you're still looking at maybe 100,000 people with undiagnosed ATTR. And finally, why should you genotype? Well, genotyping is critical because you can identify siblings of a proband and their children who are at risk for developing ATTR amyloidosis if they're carriers of the allele. Remember, autosomal dominant, 50% chance. You also can predict the course of disease, and in so doing, tailor assessments and potentially therapies, hereditary neuropathy, hereditary polyneuropathy, or both. And finally, in terms of approved drugs, as you're about to hear from Dr. Maurer, the assessment of neurologic versus cardiologic and the hereditary versus wild type is a key factor in determining the selection for available options in 2021. So I'd like to thank you very much for your attention, and I appreciate being invited.
Wow, Dr. Ruberg, you never disappoint. That was awesome. And just to say, since we actually trained together, so we are pretty much the same age, you're not old, you are experienced, and I'm going to stand by that assessment. It's my great pleasure to now introduce someone who needs no introduction, Dr. Mathew Maurer, whose name is essentially synonymous with amyloidosis. He's at Columbia University, Irving Medical Center, and he's going to talk to us about current therapies and future promise. Dr. Maurer, you can take it away.
I always forget to unmute. Hope you all can see my slides. So it's a pleasure to be here with everyone and talk about current therapies and what is a really exciting landscape in the field of cardiology, that is transthyretin amyloidosis. Here are my disclosures. So we've learned a lot about the biology of the disease. We've learned that TTR is predominantly produced in the liver as a homotetramer, and it dissociates into monomers or oligomers that form the amyloid fibrils. And the elucidation of this underlying biology has led to the development of several effective therapies. We have therapies that silence or knock down TTR, antisense, small interfering RNA, and now on the horizon, CRISPR-based therapies. We have stabilizers, including tafamidis, diflunisal that can be prescribed off-label, and acoramidis or AG10 that's in late phase development. And then, of course, we have anti-amyloid therapy, several of which are shown here, which I will not discuss because they've yet to really enter into phase 3 trials, but these are targeted at removing or extracting amyloid from affected organs. As the Europeans have recently highlighted in their guidelines, the treatment is dichotomized based on whether you have variant disease or wild type and whether you have a cardiomyopathy and or a neuropathy. And as you can see, tafamidis can be prescribed across the spectrum. For those who have concomitant cardiomyopathy and neuropathy, both patisiran and inotersen. And for those with polyneuropathy only, we have multiple different choices of therapy. The reason we have tafamidis across the pool in part relates to the ATTR-ACT trial. And I always like to highlight the baseline data because it refreshes for everyone what is the typical phenotype we're looking for. So in ATTR-ACT, there were 441 patients who were randomized to receive either tafamidis or placebo. Their average age was 75. A majority were men, but I think this suggests we're just missing the diagnosis in women. 3/4 of the patients had wild type disease. And most importantly, the ejection fraction was preserved, not normal. The wall thickness was increased. And as you can see, strain, BNP, and troponin were all abnormal with low strain, very high NT-proBNPs and troponins. And I would note that their stroke volumes are markedly reduced. This is not the stroke volume index. This is the stroke volume. Stroke volume index about 25 mLs per meter squared. And with this advanced a phenotype, it's somewhat surprising and always has been to me that a majority of the patients are NYJ class 2. And that's because this is a very slow and indolent disease. And the good news about that is then we have a big opportunity for early diagnosis if we utilize a lot of the clues and approaches that my colleagues have highlighted. As you're aware, tafamidis binds to transthyretin and stabilizes it, and it was associated with a significant reduction in overall mortality, with a number needed to treat of only 7.5 patients to prevent 1 death over 30 months, and an NNT of only 4 to prevent 1 heart failure hospitalization or cardiovascular hospitalization. So quite a potent and effective therapy. Additionally, tafamidis prevented the decline in the 6-minute hall walk. It didn't improve it, so it slowed the decline, and it slowed the decline in quality of life as measured by the Kansas City Cardiomyopathy Questionnaire. These are the average data. And so what's become clear is the earlier this drug is administered, the better efficacy we see. And these are new data from our group that I'll highlight, in which you can see we've taken a cohort of patients who received tafamidis with wild-type disease and historical controls. And this is the Mayo stage 1 data, and you can see there's a marked reduction in survival over 5 years with a hazard ratio that's more than 50%. Stage 2 disease, similar effect, maybe even slightly greater, though overlapping. And unfortunately for stage 3 disease, using a Martha Grogan's staging system, there was really no effect, further supporting the idea that this drug needs to be leveraged early in the course of one's illness. With the efficacy of the ATTR actin tafamidis experience, there's now been a plethora of clinical trials that are soon to report, or either fully enrolled or almost enrolled. So we have ATTRibute-CM looking at acoramidis or AG10 with expectations that the phase A, part A of the primary endpoint will report out later this year. There's patisiran or Apollo B using patisiran, an IV administered compound that was originally shown in the New England Journal in the Apollo A trial to be effective for neuropathy, that's focusing on 6-minute hall walk. And then there were 2 sub-Q silencer trials, the CardioTransform trial and the Helios B, leveraging plenitersen and vutusiran in very large, for amyloid, clinical trials, determining whether or not these silencers are more effective than a placebo, in some cases in the background with tafamidis therapy. So what is the hypothesis behind small interfering RNA, antisense, and CRISPR? Well, we saw before we're producing a mutant or wild-type protein that becomes unstable, that deposits in an organ and causes the phenotype. And what we're interested in doing here is blocking the production, reducing the unstable circulating tetramers, preventing deposits in the organ, ideally stabilizing or even hopefully recovering the function of the organ over time. So these are data from the Apollo A trial that included patients with polyneuropathy, a significant percentage of which had concomitant cardiomyopathy. And you can see here, these are a surrogate endpoint, NT-proBNP, and over time, NT-proBNP tended to rise quite dramatically in people on placebo, and in those on patisiran, there was a robust and significant difference between the 2 cohorts with a decline over time, suggesting a cardiac effect. Similarly, in a sub-study that we published with Scott Solomon and others in Circulation, you can see wall thickness tended to decline on patisiran, as did relative wall thickness. Global strain was stabilized. Cardiac output did not decline as much as it did with placebo, and there was a decline in LV mass, presumably related to amelioration of the amyloid load. These are old data that Dr. Ruberg and I collected many years ago in a natural history study, but I think they're very illustrative because they describe to physicians what's happening over time. At baseline, you can see in black, these are pressure volume loops, and a patient with amyloid over only 18 months has an upward shift in their end diastolic pressure volume relationship, a decline in their chamber contractility, and an increase in the ventricle's load or afterload. And collectively, you can see the area in the pressure volume loop or stroke work declines from baseline to over 18 months. And using these data to recapitulate Starling curves, you can see that there's a marked decline in the ventricle's ability to perform work. And similarly, we noted that there was a discrepancy in those who had wild type versus V122I, and a significant difference in those who unfortunately passed away, shown in blue, versus those who survived during the course of this trial. We've recently reanalyzed the data from the Apollo trial, again, in patients with predominantly and definitively a neuropathy, but many of whom had a cardiomyopathy. And these are data we presented recently showing that in individuals on placebo, there was again this upward shift in the end diastolic pressure volume relationship with a decline in the ventricle's ability to perform work that was ameliorated at only 9 months with patisiran therapy. And at 18 months, we saw that again, patisiran was more effective than placebo at maintaining the ventricle's ability to perform work and move a stroke volume and generate a pressure. Quite encouraging for, I think, future studies. Similarly, our colleagues across the pond have leveraged a CMR in patients who were receiving a patisiran therapy versus untreated controls that underwent MRIs essentially a year after treatment. And as you can see, in those who were untreated, there was progression of the ECV, indicating worsening amyloid load, and that was stabilized in those with patisiran, quite dramatic effects that suggest amyloid potential regression. The most exciting new kid on the block is CRISPR-based therapy that was recently published in the New England Journal of Medicine by Julian Gilmore and colleagues. This is kind of an amazing technology in which a TTR-specific RNA for obviously transthyretin is packaged in a lipid nanoparticle along with the, if you will, CRISPR-based therapy and delivered by a single IV infusion to the hepatocytes, and will permanently knock down your ability to produce prealbumin or transthyretin. And this proof of concept, a study in only 6 patients, there was a dramatic lowering of prealbumin and transthyretin levels after only 28 days. This would be a permanent therapy and would have potentially dramatic long-term consequences is the hope. So I'll just summarize that in the realm of transthyretin cardiac amyloidosis, in a relatively short period of time, as everyone has highlighted, we've gone from a relatively rare disease, that one in which providers are encountering all the time in practice, one that used to require an invasive and endomyocardial biopsy, but now can be diagnosed with a non-biopsy approach, leveraging scintigraphy with the associated monoclonal protein assessment, and one that used to have no treatments, and one that now, and I believe in the future, will have a plethora of therapies. So thanks for your time and attention.
Again, Dr. Maurer also does not disappoint. That was such a fantastic overview and perspective of where we've been and where we come. So now we are going to pick the brains of all of our experts so everyone knows everything. By the time we are done, we'll take the next 10 minutes or so to do that. So we have a question, and I'm going to, by one of our attendees, a very, I think, keen and insightful question. So I'm going to give it to you guys, and let's hear your take. In a patient with symptomatic severe aortic stenosis, if cardiac amyloidosis is diagnosed, should the surgical intervention be postponed and amyloid be treated first? Who wants to take that one?
Yeah, I would say that I wouldn't defer treatment for aortic stenosis. I would strongly recommend that the treatment in a patient with significant amyloid and severe AS be geared toward our percutaneous colleagues and think about ATTRv. Patients with amyloid do not like pump runs. Their hearts don't like cardioplegia. And if you think they're stiff to begin with, they get really stiff after a surgical procedure. But I had a lot of equipoise about this when we first were, if you will, unveiling patients. Many of them were very sick and ill, and I didn't think that an aortic valve intervention would be helpful. But I think our colleagues across the pond have clearly shown in both single center and multi-center studies that the outcomes in patients who get ATTRv are significantly better than those with AS and amyloid who don't. And so I think you really want to intervene on the aortic valve when your interventional colleagues think it's the right time.
I would agree with that. I love the way Matt threw in Unveil too, because that was the name of the study that he published, which was a great name. I just want to make sure we're talking about ATTR amyloidosis here. If we're talking about AL amyloidosis, you got to treat the AL amyloidosis as well. So, but I think we're presuming we're talking ATTR because that's the most common co-association. But I would otherwise completely agree with everything Matt said.
And that
patients feel better. Right? They feel better after TAVR too, definitely.
Because there's 2 processes going on. If the severe AS could be causing as many symptoms as the stiff heart could be causing, then the question becomes: here's the follow-up. if the patient undergoes their TAVR, survives their TAVR, and they're still highly symptomatic, they're like class 3 inching into class 4, do you bother to attempt tafamidis in that patient?
Yeah. Well, it becomes, oh, go ahead, Matt.
No, go, Rick.
We're going to say the same thing, I think, probably, as we typically do. I mean, tafamidis is a drug that has almost no side effects. I mean, it's like the only major problem is its cost, you know? And so I think we have a pretty low threshold to administering the drug if there's a chance it can make people feel better. I mean, in Matt's ATTRACT trial, AS patients were not included. And we know that in class 4 heart failure patients were not included. And those who were in class 3 didn't do as well. And as Matt just showed us in his reanalysis of the data, they don't do as well. That said, though, it's very hard to withhold a potentially helpful drug if there's minimal toxicity from somebody in whom it might help. So I usually have a framing discussion with people. I will say, we can try this as long as the cost to you is acceptable. And usually with good copay assistance, you can get it down to less than $50 a month. Obviously, there's a cost to the healthcare system, which we don't need to talk about right now. But I'd also say that the evidence does not support it's going to help you if you're in that particular scenario you just painted. Michelle.
I think the point I'll make too, right, is tafamidis doesn't make you feel better. It just makes you not feel worse. But not being hospitalized, living, if you survive the first 18 months and the survival curves separate, you're going to live longer. Yeah, I'm a huge fan, but that managing expectations piece has to be a big part of your discussion.
I completely agree. And I think, this gets into the discussion of patients wanting to ask, how am I doing on tafamidis? They want to look at their wall thickness, they want to look at their biomarkers. And the bottom line is everything's going to get worse over time. And so here you are checking tests that are worsening, and they're like, I thought it's supposed to. So this conversation needs to happen at the beginning, the middle, and at the end. It has to happen, I think, throughout the course of prescribing these particular medicines. The hope, I would say, is that some of these emerging therapies are more effective and potentially will be in a very enviable position with our patients as providers, that we'll be able to think about different therapies that we might switch people to or combine, though the cost issue is still going to be probably preclusionary.
So you just touched on, I have about 17 questions. I'd like to pick all of your brains. So while we're waiting for more things from the audience, Dr. Maurer, you brought up something, the follow-up imaging and surveillance. So it's harder to say no than it is to say yes in life in general, to patients in particular, to patients with amyloidosis most of all. So do you do these things, or do you say no, it's not going to change my management, I don't want to know what's going on with your heart after you start tafamidis?
I, in general, discourage patients from getting routine testing, that is echocardiograms. I think there's a role for, to be honest, ambulatory ECG monitoring because of the risk of atrial fibrillation. There's a high degree of conduction disease and people fall and syncopize. I try to describe to them the variance that we all know exists in echocardiographic readers, and the chance that meaningful change is due to reader A versus reader B is more likely than there's been a demonstrable change. In the ATTR-ACT trial, there isn't much happening with the heart except for a slowing, as Michelle pointed out, Dr. Kittleson, of the decline in the stroke volume. That's where all the money is. And we don't spend a lot of time quantifying stroke volume. I do measure biomarkers consistently over time, but I think the more important thing is to ask people, as we all know as doctors, how they're feeling, what they're able to function, what they're able to do. That's what really impacts on older adults' health and well-being. Are they functionally independent?
I'd agree, and we also track biomarkers, and we do check echo because that's just what we do. But I agree with you. It's not so much to identify the efficacy of the treatment at this point, because there are no other options for most patients with wild type ATTR. I mean, what else are you going to do? They're at the present time. In the future, that may become more important. And and as Matt also illustrated in his talk, there's some issues. There's some potential benefits of cardiac MR and looking at change in ECV and things like that, which we could talk about, but it's not going to change how you manage the patient at the present time. We often, though, look for other things. I mean, these are older people. Sometimes they get coronary disease that causes problems. Sometimes they get pacing, or too much RV pacing, and they develop declines in systolic function, and you might want to upgrade them to CRT. So, and as Matt said, we also survey people actively for atrial fibrillation because of the high concordance. But in terms of looking at the efficacy of therapy, it's not clear it's going to make a difference.
So 2 points I'll highlight from that erudite discussion. When you have atrial fibrillation, right, it doesn't even matter what your CHADS2 VAS score is. You put them on anticoagulation. In fact, some would say even if they don't have atrial fibrillation, put them on anticoagulation, though that is not standard. If you find atrial fibrillation, don't think, just start your DOAC. And I think the second point I lost the second point as I was getting all, so I'm going to go on to my next question for you guys. So here's what I want to know. We talked about the end stage of the disease and how we all become experts in end stage management of these conditions because they're by definition older and they get sick towards the end, and we don't really change the natural history appreciably in that sense. But what about those gene carriers, those asymptomatic gene carriers? Do you ever, and they feel amazing and their echo is fine, do you ever do other studies? Do you ever do a cardiac MRI or a technetium pyrophosphate scan because the worst words in medicine, just want to know? Or do you go by your clinical gestalt and their echo?
I mean, I think it's pretty clear that you want to try to identify the phenotype as early as possible. So if you have an allele carrier who's within 10 years of when the proband, their family had disease, I think you want to start to look pretty carefully. We don't know, to your excellent question, whether or not PYP is better than MR. I don't think echo is the right approach. I mean, you can get an echo, but it's not going to tell you much. And treatment-wise, to be honest, in those individuals, one could argue that prescribing diflunisal, which is a non-steroidal that has TTR stabilizing properties in someone who has no yet phenotype, might actually delay progression of disease. So it's a discussion that I have with patients. They come in different flavors, as you know. There's the people who don't want to hear anything about any of this, and you're not going to influence their decision. And then there's the extreme of the unbelievably worried. And you have to, I think, be a doctor first and recognize what the phenotype of the patient is, both clinically but also psychologically. There's a lot that goes on in thinking and knowing you have a predisposition to a genetic disease.
Yeah, 100% agree. And as of course, and I think that the other points that I wanted to make about that are, first of all, I mean, there's a lot of gene carriers who are not even close to where their disease prevalence is likely to occur, clinical penetrance. So a V122I 30-year-old is not likely to, it may have important implications for their children in the future, and certainly their parents and their aunts and uncles, but not them in particular. So it all becomes it's a discussion of education about what the significance of this carrier is, educating them that the phenotypic penetrance is not necessarily complete, and then kind of framing the expectations for what to look for and when to start assessments. But I would also say that people are getting their own genotypes, even in the absence of any sort of like clinical disease in the family. And this is something that we, all of us, are seeing, where people are getting one of the commercially available, kind of in-home genetic tests. They get read out a result, and then they don't know what really to do with that, and they're quite concerned. And so I know Matt has thought about this a lot in particular. And so I think that we should, be prepared that people are going to be asking these sorts of questions, and we need to have some guidance as to like how to approach them.
We'll end with a final question. I'm not going to make it easy on you guys. Like I said, we're picking your brains. We've gone through the extremes, really sick, really healthy, other conditions. Let's go back to the patient and the clinical clues and the red flags. What are the top 3 things on echocardiography that make you suspect amyloidosis? Because you're not going to find it unless you order the right test. What's going to make you order the right tests?
LV hypertrophy is going to definitely evoke the diagnosis, and we have a lot of patients referred to the echo lab with a LV hypertrophy, or either because of people thought it was a hypertensive or HEM, and coupling LV hypertrophy with LV strain is going to help a lot in the diagnosis of amyloidosis. And maybe we can say a third point, the diastolic dysfunction as well, with go forward into the diagnosis of cardiac amyloidosis, and will trigger the bone scintigraphy and lately the cardiac MRI.
Awesome. Well, everyone, you've got it. I'm going to hand it over to Dr. Mishi to close out our session.
Thank you so much. This was really a very inspiring webinar because I think in our cardiology training, and even afterwards, sometimes I think we're missing some of these delicate diagnosis. So I personally, I learned a lot from you. So I will have to watch it again in order to, you know, to fix all the information. Thank you so much for participating. I think the audience was astonished, and I hope to see you soon, maybe in another webinar. Thank you so much, Michelle, Matthew, Frederick, and Benjamin. Thank you.
Thanks for having me.
Thank you.
Bye.